I'm glad that I got the opportunity to present and unlock some of the insights about liquid biopsies in hepatocellular carcinoma diagnosis and monitoring, which is one of the most evolving areas from last few years. So this is the brief outline of my talk, which I will try to cover in next 25 minutes. Though I'm a basic scientist, but I would like to focus my talk on the clinical point of view, that where the liquid biopsies can help us in the clinical setting. So starting with where exactly we need HCC biomarkers, what is liquid biopsy, its concept and potential in terms of clinical applications, the unmet needs in HCC management, surveillance, and improve the early diagnosis, prognostication, post-treatment follow-up in early and advanced stages. So to start with where exactly the liver cancer stands. So this is a summary slide of estimated number of new cases and the deaths per year. And in terms of new cases and mortality, lung stands the first and liver is almost on the third number. And this dot represents the lethality. The bigger is the dot, the larger is the lethality. So the first number is pancreas. The second, in terms of lethality, liver cancer stands the second. So as we already know that it is very rare to develop hepatocellular carcinoma in the absence of any chronic liver disease condition. So during this progression of the disease, the risk of HCC increases 1 to 3% annually. So now that is more relevant or rational for surveillance program among cirrhotic patients. That means all the cirrhotic patients should undergo the abdomen ultrasound or AFP after every 3 to 6 months. Whereas in certain cases, the HCC develops directly from chronic hepatitis. So for such patients, we do not have any surveillance programs scheduled due to unavailability of definitive markers. So another thing is, if we look at the current workflow to diagnose hepatocellular carcinoma, the best would be if we have a tissue biopsy to identify nodular size, hypervascularity. But due to its invasive nature, we go for radiological tests, which are the standard methods presently. And if there are typical features, it is fine, but in case of atypical features, we ought to have a tissue biopsy. And if it is negative, the ultrasound needs to be repeated after 3 to 6 months. So another issue is that the imaging techniques are available only at the Center of Excellence, where the best of the radiological equipments are available. And if we look at the clinical management of HCC patients, this is the BCLC staging algorithm, Barcelona Clinic Liver Cancer Staging. According to this, patients are classified into 5 different stages based on liver function, tumor borders, and the performance status of the patients. And each stage is actually interconnected and linked to different type of treatment regimes and prognostic estimation. But still, there is no reliable marker which we can say is available for such type of estimation. So the question is, can the biomarkers help in this scenario? So serial tissue biopsy. So we know it's invasive procedure. There are many risk compounds associated with this. It's inaccessible, it's expensive, and one-site heterogeneity is present and cannot access the tumor burden. So, and also there's a risk of seeding. So do we have an alternative, a solution? So we can say yes, as this can be resolved by using liquid biopsies, which are dynamic instead of static biopsies. For those who are not very familiar with it, liquid biopsies means isolation, analysis of tumor components that are released in the bloodstream or any other biological fluid such as saliva, ascites, stool, urine. But the majority, we prefer the blood samples. And this has 3 major components from the tumor that are released in the blood, which are isolated and quantified and can be measured. One of the component is ctDNA, or we can call it circulating tumor DNA or cell-free DNA, which are cell-free DNA fragments circulating in the plasma. When the tumor cells undergo death, these DNA fragments can circulate in our bloodstream. The second is circulating tumor cells. They are the tumor-associated cells which come into the biological fluids, and it can be immune cells associated with it. So third is extracellular vesicles, which are the miniatures of tumor cells. I can say they are small in size, cellular embedded vesicles which are released by each cell type and carrying information in terms of small RNA, DNA, or proteins. So if we go into the details of ctDNA isolation, detection, and analysis, which has actually revolutionized in the field of cancer research and diagnostics. So the isolation of ctDNA involves extracting and purification of these fragments from patients' blood samples. And this process typically involves centrifugation, filtration, or immunomagnetic separation techniques. So once it is isolated, the cell-free DNA can be detected and analyzed using various methods, such as RT-PCR or polymerase chain reaction, digital droplet PCR, next-generation sequencing. And these techniques actually allow us for a sensitive detection of even minute quantities of DNA, ctDNA, and provide a non-invasive alternative to the traditional tissue biopsies. And this analysis of ctDNA is crucial information about tumor-specific genetic alterations, including mutations, copy number variations, epigenetic modifications. And this data might enable clinicians to monitor tumor dynamics, assess treatment responses, detect minimal residual disease, and identify the emergence of drug resistance mutations. And the turnaround time, which I have implied according to ILBS, is around 2 to 3 days. So next is the circulating tumor cells, which are cancer cells that are detected from the primary tumor or from the tumor microenvironment, which enters into the bloodstream. So isolating CTCs from a patient blood sample is challenging due to its rarity compared to the normal blood cells. So various techniques are employed for CTC isolation, such as immunomagnetic separation, microfluidics, filtration methods. And these methods actually rely on capturing CTCs based on specific surface markers or their physical properties. So once isolated, these CTCs can be detected and analyzed using different approaches such as immunofluorescence. And in this picture, we have CTCs using an imaging flow cytometer, where we can capture APCAM positive, one of the cancer tumor cell markers, and we can capture CTCs together with its nuclear staining and its marker. So increased level of CTCs are usually associated with poor prognosis of cancer, and amount of CTCs are actually present in a very minute quantity in the blood, which needs to be enriched, and it's the essential part. So other methods for CTCs based on charge, density, and deformability, they are under the pipeline. So whole tumor cells are released, and it's in the bloodstream, and the turnaround time is 5 to 6 hours. So next is the extracellular vesicles, which I mentioned are cell-derived membrane-bound particles, which can be considered as fingerprints of tumor cells, as they carry a lot of information about the tumor cells in terms of small RNA, protein, or cell surface marker. We cannot actually go to the tumor and find out the microenvironment, but this can be the miniatures of tumor cells, and we can capture the information in the plasma about the microenvironment of the tumor. So if we look at the isolation is concerned, it involves separating them from the complex mixture of biofluids such as blood, ascites, urine, and even stool, typically through ultracentrifugation, density gradient centrifugation, size exclusion chromatography. So once isolated, EVs can be detected and characterized using various techniques, such as electron microscopy to visualize the morphology and size of EVs, and which nanoparticle tracking assay or dynamic light scattering can determine their size distribution. The surface markers specific for EVs are CD3 and CD9, which can be detected using immunoblotting or flow cytometry. Furthermore, the analysis of EV cargoes in terms of proteins, we can get it proteomics done, nucleic acids, NGS, lipidomics, which provides valuable information about, as I said, tumor microenvironment and the genetic profile of HCC. Again, the turnaround time can be 2 to 3 hours. So let's go to the unmets of HCC management. I think the first one is surveillance, and we know that HCC is rising more and more, and almost 80% of the cirrhotic patients actually develop HCC. For this rise, we need to have improved surveillance or early detection programs. So this data is from the West, and if we have, consider this, if we have 600,000 cirrhotic patients, that means almost 2 to 3% annually have the risk to develop HCC. And now, if we have that performance of recommended tools for early detection of HCC, that is AFP or ultrasound, the sensitivity is almost 63 to 64%. And almost the 40% of the cases will go undetected. But the meta-analysis, which is published in 2020, shows a different scenario, that actually the cirrhotic patients which enrolls in the surveillance program is very low and shows only 24% of the patients which undergo the surveillance program. The implementation rate is only 24%. So if we compute among these, that means 18,000 cases were at risk, and only 24% will be enrolled in the surveillance program. And knowing that performance of the present tools is, that means only 15% of the patient at risk will be detected. And almost 15,000 patients will go undetected, because either they are not under the surveillance, or because of the bad performances of the present tools available to detect the early stage of tumors. Hence, there are two barriers for early HCC detection, and which we need to improve the accuracy of the tools and increase the implementation rate. So we need to have a method which is much more simpler, less expensive, and the patients also get it done by their own. They can go to the pharmacy and buy a kit, and they can perform on their own. So there are some recent studies which I will discuss about the early detection. It is on the mutation profiling of circulating tumor DNA or cell-free DNA in hepatocellular carcinoma. So this is the study which had a mix of molecular known mutations and tumor markers like AFP. And this has been studied in the cohort of 3,800 HBs antigen positive patients which were under the surveillance program. You can look at this, that they took a training set which had either the raised AFP or the presence of liver nodules. And in the validation cohort, they had almost 331 patients with normal ultrasound or AFP. And among them, they were able to find almost 17% they detected the HCC. So, and all were at the early stages. They had 100% of sensitivity and 94% of specificity. Though the positive predictive value was low, but still they were able to detect in the patients which were normal for AFP and ultrasound by using this mutation profiling of cell-free DNA in HCC. So this is another study which is very interesting and one of the most popular studies, which they reported methylation profile of cell-free DNA, and they have measured almost 10 plus plasma methylation markers and screened more than 1,000 HCC patients from all stages. Though they compared with the healthy controls, but the good part is in the study, they had a high sensitivity and specificity to detect the early stages of HCC. And in fact, their specificity and sensitivity was so good that they actually got FDA approval for their trial in cirrhotic patients. and methylation markers blood test alone and combination of HCC detection in cirrhotic patients. So the prospective clinical trial to detect liver cancer through quantification of cell-free DNA methylation in blood sample. There are not only this clinical trial, but I found a couple of them which were under investigation. If you are interested in, it's HCC screen, OncoGuard, IVGen-DX, or HCC blood tests, which are still under the pipeline, and we are waiting for their positive results. So another recent study by one of the famous scientists, John Feldman from Mount Sinai, using exosomes, in which they isolated the exosomes from almost 209 patients and identified the small RNA using the NGS. And among them, they identified small RNA clusters, which were significantly upregulated in HCC cases compared to the control. And also to mention in the study that all the HCC cases were of early stage, and the controls they were using were not healthy. They were chronic liver disease, which were part of their surveillance program. And if you look at the performance of these three small RNA markers compared to the AFP or ultrasound, it has a sensitivity of 86% and specificity of 91%. So next question is if we can improve the prognostication and post-treatment follow-up. So this is again another mutation profiling of cell-free DNA, in which they collected 30 early HCC patients prospectively undergoing curative treatment, 27 resection and 3 ablation, and investigated the most common mutations available for molecular profiling of HCC. And if you see just the amount of total ctDNA, it clearly correlated with the survival of the patients. And also on the number of mutations, they were able to separate the two populations based on the survival. So they all monitored the known mutations, which I'm showing that which I'm not showing it here. What they have done is they followed up all the patients each month and looked for different type of mutations, and they also identified and segregate from survival to non-survival. So CTCs are also one of the important ones, the circulating tumor cells, and studied in the prognosis of HCC. So in this, they investigated the circulating tumor cells identified on the basis of epithelial cell marker, vimentin, and based on it, they were able to segregate the patients from early to the advanced. And in comparison to AFP, which has a specificity of almost 64 to 66%, it has 89% of specificity, which was also correlating with the survival of the patients. And though the results are interesting, but it needs to be validated as the number of sample was low in this study. So according to BCLC stages, also people have done circulating tumor cells. This is again 74 patient profiling of CTCs, and here they have used the marker of EpCAM and mucin-1 together. And they were able to identify patients with the CTCs less than 5 cells per 8 ml had significantly longer survival than those with CTCs more than 5 cells in 8 ml. In the multivariate analysis, the CTP score of B, BCLC-B, BCLC-C, and AFP more than 400, and CTCs more than 5 cells, they were independently associated with the survival. The larger number of peripheral CTCs is correlated with higher tumor aggressive features and poor survival in HCC patients. So now the advanced stages, it is actually the hot area as immunotherapy has completely changed the landscape of treatment regime specifically for advanced stages of HCC. So for many, many years, we know that we had been using sorafenib, but now the sequence of treatment has changed. So looking at the different stages as different treatment regimes, it is becoming very important to identify the right candidate and also the follow-up or treatment response. as we know that oncologists might suggest us better, that only 20% of the patients actually respond to the immunotherapy. So we really need biomarkers or liquid biopsies in this condition. So this is a study again from Felden group from Mount Sinai, the ctDNA profiling in response to tyrosine kinase inhibitor. So this was a retrospective study. They have already done it earlier, but they also found it is directly correlating of the mutation from ctDNA and clinical outcomes, and it confirms their previous findings from the tissue-based biomarker with a better specificity and better sensitivity level. Another we know is the checkpoint inhibitors in hepatocellular carcinoma, one of the famous studies. In this also, they wanted to understand that which patient will respond and which will not. So they utilized circulating tumor cells and used PDL1 positive and PDL minus as a marker for differentiating the cells. So if you look here, they are the PDL positive absent and PDL positive present patients. They were able to segregate, and the yellow bars are actually the responders and the blue bars are actually the non-responders. Even at the baseline, before giving the therapy, they were able to find out who will respond and who will not. So the blue ones, which were non-responders, were having PDL positivity was absent in them. So there was no PDL positivity. So coming to the liquid biopsies at ILBS, though we have not done it in terms of hepatocellular carcinoma, but I would like to prime you that yes, we have a scope at ILBS and we can do it here. We were able to isolate and enumerate the extracellular vesicles, or we can say microvesicles, from severe alcoholic hepatitis patients. And this work is already published in APNT way back in 2018. And we were able to identify from electron microscopy and NTA. And in this, we were able to see that hepatocyte-specific or CD34-specific EVs at the baseline were able to predict the non-response to corticosteroid therapy in the SAH patients. And these two populations were able to be segregated in terms of their response to steroid therapy. And if we combine both of them, the specificity was almost 92% for this test. So we have a biobank available in our center, and we are privileged for it. So we all may aim to develop an algorithm that can combine various biological fluids to obtain precise tumor profile. And I think we all can have a liquid biopsy repository consortium and may develop this field to a next level. So to summarize, HCC we know has a poor prognosis, mainly related to diagnosis at the advanced stages, high risk of recurrence and resistance to therapies. And the potential role of liquid biopsies in these settings is the breakthrough device designations for surveillance and early HCC detection. The cell-free DNA or CTCs or exosomes have a significant potential for prediction of recurrence, prediction of response to systemic treatment. So technology is evolving and results are promising, but further research needs to be standardized, more validated in a larger cohort without any operator, reduce the operator variability, minimize the false negative results by defining it to the methodology, detection, quantification, and also the study design, patient selection. And before it comes into a clinical practice, we need more and more clinical trials. Thank you.
Wonderful, Sukriti. I'm not from this field, but I definitely understand the importance of liquid biopsies here, and I'm sure they will have an importance, like you mentioned in your biobank slide. That will be important even in other diseases apart from SCC. My question is, maybe it's a very basic question. I just wanted to ask you. You were showing a slide where there were studies which the control group was CLD in them. So most of our SCCs who come, they come with a cirrhotic background. So how is it going to be reflected there? Is it going to be?
So their idea was that early detection of HCC, if we can enroll CLD patients into the surveillance programs or early detection, these markers will capture them. And the AFP or ultrasound will tell us after 5 years that this is going to go in HCC, but these liquid biopsies can actually help us 10 years ahead that this patient might undergo. So we can plan some treatment regimes for them. So this will be very helpful for surveillance and early detection.
I would